so pleased to be with you now for the complete story 4. Complete story 4, we will talk about very important topic in critically ill patient, which is the value of ultrasound in acute renal failure. I was asked to assess an old Baba, 70 years old male in male medical ward. He has multiple comorbidity, hypertension, benign prostate hyperplasia, and diabetes mellitus. He is now hypotensive with worsening of renal function. Serum creatinine reached to 4.3 milligram deciliter, coming from 1.8. Yes, this is the first assessment of our patient with acute renal failure. Usually, we assess cell volume status. You see here, this is the subcostal view of the inferior vena cava. This is the left lobe of the liver, and this is the inferior vena cava. You see, it is narrow, and with breathing, it's totally collapsing, almost totally collapsing with breathing. Okay, this is the radiology view because the mark on the left side. You see again, our patient has evidence of hypovolemia, definite evidence of hypovolemia. Okay, let us see. This is the M mode of the inferior vena cava. I activate the M mode cursor here on the inferior vena cava, just below the hepatic vein, and I will see the maximum diameters with minimum diameters. You see the maximum diameters here is 0.97. It's less than 1 centimeter, and the collapsibility almost more than 50%. That means our patient is hypovolemic. Okay, after assessing the inferior vena cava, usually go to the heart to know other causes of the heart causing hypotension, and at the same time to assess if there is any kissing heart if the patient is septic. Okay, let us see. This is a two-chamber view of our patient with the anterior wall here, anterior wall of left ventricle here, and the inferior wall here. You see clearly here the inferior wall is aneurysmal and almost non-contracting, akinetic, almost akinetic in the inferior wall, and the anterior wall is hypokinetic. There is thickening in the anterior wall, but it's hypokinetic. And the visual assessment of ejection fraction here, by ejection fraction by visual assessment, it's almost 20%. Okay, so there is evidence of ischemic heart disease in our patient. This is the 4-chamber view, or it's 5-chamber view because the aortic valve is appear here. This is the left atrium, mitral valve, left ventricle, right ventricle, and aortic tract, and aortic valve. You see the calcification here of the aortic valve, bright echogenic, highly echogenic, and the calcification of the tip of the mitral valve, and you see also there is almost akinesia in the basal septum, and overall ejection fraction it's almost 20%. And you see here right ventricle is almost collapsing with contraction. I'm sorry, this is not good picture, but the patient is a bit difficult, has difficult window. But you can see here right side is collapsing. This is also a sign of hypovolemia for the patient. So despite the patient has ischemic myopathy and the bad ejection fraction, but there is narrow inferior vena cava and collapsing narrow right side. That denoting definitely our patient is hypovolemic and ischemic cardiomyopathy. Okay, to fit the puzzle together, after that you should, after you document the patient has ischemic cardiomyopathy as evidenced by akinesia of the inferior wall, with basal septum, with anterior wall, hypokinesia, you need to know about the diastolic state of the patient. You will put a pulsed wave in the tip of the mitral valve and activate the pulsed wave Doppler. I saw that in our patient. This is the E wave and this is the A wave. E wave is shorter than A wave. That means it's grade 1 diastolic function, impaired relaxation. That means our patient is not in pulmonary congestion, and the left atrial pressure is not high because it's only grade 1 diastolic dysfunction, which is early delayed impaired relaxation. But if, as I said in the 2 cases before, if the left atrial pressure and wedge pressure is high, you will expect to see this A wave is taller than A wave, more than twice or almost 3 times the A wave. But this is not the case here. The E wave here is shorter than the A wave that leads its grade 1 diastolic function and fitting with our patient because our patient is hypovolemic. Okay, now we can stop in this point. Our patient has element of hypoperfusion and due to ischemic cardiomyopathy and hypoperfusion because of hypovolemia. This could be a cause of acute deterioration, but and it could be renal cause. It could be there is embolic obstruction of the renal circulation by the because of ischemic dilated cardiomyopathy. So, the beauty ultrasound machine give us 2 causes of acute deterioration now, or 2 possibilities of acute deterioration now, which is hypoperfusion due to ischemic myopathy and hypovolemia, and at the same time could be renal cause due to embolic obstruction of the renal vessels. It's rare, but it could be. Okay. What else? Traditional teaching for acute renal failure, it is pre-renal causes, it's the renal causes and the post-renal causes. So, when you talk about the value of ultrasound in acute renal failure, you should assess for obstructive causes of acute renal failure. Let us see for our patient. Oh, it's very clear here our patient has distended urinary bladder in sagittal view, and this is the prostate. It's prominent here, and almost there is turbid urine as well. That means our patient has an obstructive element for his acute deterioration of renal failure, and they may be infected, and the definite may be infected urinary tract infection, urinary tract because of this turbid urine. But check, it's not only the obstruction in the level of the bladder, you should check obstruction at the level of the kidney. Let us see. This is the left kidney of our patient. Left kidney of our patient reveal very important pictures here. Left kidney is supposed to be, this parenchyma supposed to be more hypoechoic than the nearby spleen. But in our patient, the parenchyma is more dense, more white, more echogenic than spleen. That means it's grade 2 nephropathy. At the same time, the capsule of the kidney should be smooth. This capsule is irregular. Third, here the hilum of the kidney supposed to be all white because of renal fat. If you see these fluids, anechoic fluids in the hilum of the kidney, that means there is obstruction. Because there is obstruction, there is retained of urine, and the retained urine appear as black. So, in this picture of the left kidney, we can say there is obstruction, element of obstruction as evidenced by anechoic fluids here, and there is also renal cyst here, and there is element of chronic renal disease, chronic kidney disease, as evidenced by irregular capsule and echogenic parenchyma. This is the right kidney, almost the same. Echogenic parenchyma, irregular surface, there is renal cyst here, and inside there is, you see even pelvis is dilated. The pelvis here is dilated because of retained urine, anechoic fluids inside the hilum and the pelvis, and this is renal cyst. Okay, very good view. It's almost the same as the left kidney, but there is renal cyst here. So, really amazing. All causes of renal failure you can expect by this beauty ultrasound machine. So, let us fit the puzzle together. Our patient has chronic kidney disease, as evidenced by echogenic parenchyma, irregular surface, echogenic parenchyma and irregular surface. And at the same time, you can think about four precipitating cause of acute deterioration. You can think about hypovolemia, you can think about hypoperfusion due to ischemic cardiomyopathy, you can think about obstructive element because of prostatic hypertrophy and urine retention, you can think about urinary tract infection because of the turbid urine. Yes, it's really amazing. It's really amazing. I always say, and you will always hear from me, a lot in one shot. This is the value of ultrasound in critical ill patient. You can get a lot of information in one shot of the ultrasound probe. This is the case, and this is, you will see in every case I will present here. You can get a lot in one shot, okay? Well, and this is the value of ultrasound in diagnosing acute renal failure. Let us see how can we do for our patient. Management, definite decompression of the kidney by full catheter should be, okay. Controlled, targeted IV fluids. Always you will say from me here, you will hear, you will hear from me here that any IV fluid is a drug, and you should give IV fluid in a proper amount and the proper time. If you give more IV fluid, you are giving toxic drug to the patient, okay, because overload is killer. So always we are talk about controlled targeted IV fluid. Let us see what is meant by controlled target IV fluid. This is the baseline. As I said to you, always in this 5-chamber view, I will put the pulsed wave in the aortic tract, and I will activate the pulsed wave Doppler. I will see this VTI, velocity time integral, which is the Doppler flow coming, Doppler signal of the blood coming out of the ventricle in the left ventricular outflow tract. It is blood coming away from, moving away from the probe, which is here, so it will appear in the below the baseline. You can consider this Doppler signal, you can consider this VTI, velocity time integral, this flow in the left ventricular outflow tract, you can consider it as stroke volume of the patient, which is here 8.85 centimeter. So you, for the patient's hypovolemia and for our patient, you can give boluses of the fluid. You can give repeated boluses of the fluid, IV fluids, as long as VTI is increasing by 12% from this value. That means your patient is fluid responsive, and you can keep going until VTI not increasing by 12%. You can stop here. This is a controlled targeted IV fluids. Let us see. This is first the inferior vena cava of the patient before IV fluids, and this is after IV fluids. Okay, we reach it here, maximum diameter 1.67, it was here 0.9, and the collapsibility almost here became 30%. This is fair enough for the patient with ischemic cardiomyopathy. It's fair enough. You can keep the inferior vena cava in this less than 2, and at the same time it is 30% collapsing, almost 30% collapsing, or 30 plus 32 collapsing. It's fair for the patient's heart failure, as long as you are following the VTI. This is the VTI before IV fluids. We see 8.85, and this after IV fluids 16.7. We keep going until almost double, increased not by 12%, by 100%. This is in sequence, in bolus of IV fluids. After that, our patient blood pressure improved a lot, and fortunately he didn't need inotropes, but creatinine is still in the high side because the patient has chronic renal impairment. As you see, ultrasound has a very great, highly great value in assessing of acute renal failure. Thank you a lot for your appreciated listening, and inshallah we'll see you in the complete story 5 soon, inshallah. Assalamu alaikum. Bye.